introduce Tom Hubbard. He's the Vice President for Policy Research at Lehigh, a non-profit health policy research organization headquartered in Cambridge. Lehigh brings together about 90 member organizations that span sectors of U.S. healthcare, including patient advocates, provider organizations, health insurers, and other healthcare purchases and life science companies. Lehigh's research and analysis draws on member organizations' expertise to find common grounds on evidence-based and innovative solutions to important challenges in U.S. healthcare. At Lehigh, Tom leads projects on policy to support improved patient medication adherence and medication management, as well as projects on prevention and wellness and comparative effectiveness research. He previously served as Vice President at the Massachusetts Technology Collaborative and Economic Development Agency in Massachusetts, as Executive Assistant for Economic Affairs for U.S. Senator John Kerry, as Deputy Director of Economic Development for Massachusetts Governor Michael Dukakis, and as Director of Community Development for the City of Gardner, Massachusetts. I'd like to introduce Tom.
Well, thank you very much, and thank you for the invitation. And this isn't the first time I've seen a presentation from Monica's program, but it's been a while. And of course, I'm sitting here thinking, well, this is like being the guy who comes up after Babe Ruth in the lineup. And we talk. Thanks to a lot of folks like yourself, a lot of folks that come out of the city. The triple aim in healthcare, which we may be talking about, discussing, or studying, improving patient outcomes, improving patient experience in healthcare, and cutting costs appropriately as the triple goal for improvement in American healthcare. And in listening to Mike's presentation, I'm thinking like the triple jaw drops of the level of need that you're addressing in the program, the level of ingenuity that's been brought to it over the years to try to address that need, and the fact that just about every important issue in American healthcare is sort of somewhere in that presentation, and a policy response to it, or an innovative response to it. So I'm going to talk about, I hope, in some ways, how some of the lessons which I think have come out of experiences like Boston Healthcare for the Homeless are being played out, or being attempted to get played out on sort of a mass scale for a much more, a less acute population, let's say. And I'm going to shamelessly play to the pharmacy interest here, quite frankly, and the main slant of what I'm going to say is all about the role of pharmacy in medication practice as a really sort of underutilized, as yet underutilized response to the challenge that we have in healthcare generally in the U.S., which really is around the triple aim. How do we have our data needed to? How do we improve care? How do we get better outcomes for patients, but get healthcare on a sustainable financial course going forward? And I'm going to race through this because I want to make sure we have enough time to get to questions. So it's I'm going to pile a lot in, but I hope it will be useful for folks. And in a lot of ways, I think what I'm going to say could be framed up in just saying something that's maybe commonly obvious, that we are all about talking about patient-centered care these days as the route to giving patients what they need and what they want and getting on a sustainable course. And Dr. Tulgawande, who practices just down the street at the Brigham and Women's Hospital, a couple of years ago talked about patient-centered care, likened it to a pit crew for race car drivers. And the thought here is that when you pop the hood of the car for that high-performance race team, a lot of what's under the hood is all about meds, because what we do, obviously, in medicine most of the time these days is prescribe meds and try to get patients to take meds and see that it's done effectively and safely. So not that you need to know this, but meds are ubiquitous in medical practice. The people at the highest risk, such as the folks that Dr. Burrell talked about, tend to be the folks that use the most drugs. Good medication use, some might talk of it in terms of responsible use of medicines, a good use of medicines, a coordinated use of medicines, is very definitely seen as a priority for improvement in U.S. healthcare. This is just a reference to what is one of the most recent and fairly authoritative attempts to cost that out from the IMS Institute. IMS, and some folks in the room probably know better than I, they have all the med data. And they've costed out, as of last June, the cost of 6 different types of poor use of meds in the system, non-adherence being one of them, but also, as you can see up here, medication error and suboptimal usage of generics and so on and so forth. And they costed it all out at about $200 billion a year in sort of futile or wasteful or avoidable medical spending as a result of all of that. And I think very importantly in the policy world, and this may or may not be something that folks are sort of onto here, is that you know, there's these certain things in policy that you just sort of assume are common sense. I mean, that people must be acting on this, and so one might have always assumed that, well, you know, people are prescribed medications appropriately and they take them, they're not going to get sick, or the progression of disease is going to slow down. It's going to avert more serious healthcare spending down the line, and therefore we ought to encourage good use of medications as a way to tamp down medical spending. Well, that wasn't something that could be proven to the satisfaction of the Congressional Budget Office until last fall, about a year ago, actually. And the reason that's important, as folks may know, is that the Congressional Budget Office is the referee for legislative change in the Congress, and bills that involve money go to the Congressional Budget Office, and they quote-unquote score them to say what the likely impact is going to be on federal spending and on federal deficits and on federal debt and so on and so forth. And it wasn't until a year ago that they were willing to conclude, based on the volume of evidence that's built up, that at least in Medicare, more prescription activity equals less medical spending for Medicare in a given year. It's a very sort of gross, blunt instrument kind of assessment that they made, but it was sort of a watershed moment in a lot of ways for medication policy, at least in Medicare, and may open the door, at least means that folks in Congress, and particularly the CBO, have their ears open a little wider to ideas about how to coordinate medication and, frankly, use of pharmacy services as part of the solution to healthcare costs going forward. So things you might not have been aware of. Now, here's what I think is a vivid demonstration of this. This is an article that came out over the summer in the Journal Health Affairs from a team led by Bruce Stewart, who is an economist that teaches at the University of Maryland Pharmacy School. And what Professor Stewart and his team did was to parse through a whole bunch of Medicare data to try to show what the differences in medical spending might be tied to different patterns of medication adherence. And again, things that you probably thought are sort of common sense, if folks just don't take the meds and they're going to get sicker. Well, indeed they do. And what was, I think, interesting about the study that Professor Stewart and company did was that they teased out different patterns of adherence among these patients. So this is just a chart on the monthly Medicare spending for patients who are diabetic, but parsed out by their level of adherence or pattern of adherence to ACE inhibitors. And about 3 years out, according to their data, there's a $500 a month gap between the patients who are faithfully adherent and those who are not adherent or inconsistently adherent. And of course, that's serious money by anybody's calculation, including Medicare. So that is the target that's out there. So takeaway, I guess, is that medication use is increasingly seen as a target for cost savings. It is already getting more and more hardwired into various quality metrics that are increasingly tied to the way people get paid in healthcare. Now, it's not, at this point, always tied in very explicitly, and adherence in particular is not always tied in explicitly, but Monica mentioned the NCQA standards and so on. If you look at the standards for the patient-centered medical home, you look at the standards now for accountable care organizations, which are increasingly coming on the scene. A lot of it is about targets that can't be met unless you have good use of meds and adherent use of meds. And in one area in particular, which is, I think, very important to folks in the pharmacy world, in the Medicare drug programs and in the Medicare Advantage programs, they do get rated, as you may know, they get these star ratings on their performance, whether their patients are hitting various goals. And the star ratings right now in the Medicare drug plans are about 40% weighted towards direct measures of adherence, and it's in the area of the ABCs, so it's blood pressure control, cholesterol control, and adherence to oral diabetes meds, so pills for diabetes. So adherence in medication adherence and good use of meds are, as people may or may not be aware of throughout the whole medical world, are getting more and more, as I say, hardwired into the way people are getting evaluated. So the stakes are very high for this. There's a lot of reason now to try to get more out of medication management and improve adherence in particular to reach these goals. But I'm not a clinician, so I feel duty bound to remind myself at least why hasn't this happened already? Well, it's hard, clearly, and we got a taste of that, I think, in the first presentation. Medication regimens for the people that we tend to focus on tend to be really complex. So it's, we care about every patient on every pill, but the folks that we're really focused on and the folks that are driving payment incentives in particular are people that are at high risk, people that have complex needs, people who have multiple conditions, and they almost by definition are on multiple meds and frequently on multiple meds that are prescribed by multiple prescribers. So right at the get-go, there's a management issue. And so what we need right from the start is to try to make sense of this in a way that is safe, leads to effectiveness of the therapy, and tries to achieve what you might call some adherability. Is it setting the patient up to be able to actually accomplish this medication use day to day? Medication processes are notoriously what many would call leaky. There's a lot of slips, including the gap that occurs all too many times historically between the patient getting literally a slip prescription and taking it to get filled, because they may take the slip, but they may not get it filled. This is just one chart of one slice of the process. This is from the Jewish Healthcare Foundation out of Pittsburgh, which did an exercise about 5 years ago now on tightening up medication practice just in the hospital. And so there's sort of whiteboard exercise on what ought to happen. And you'll notice the line that goes around to the left there. That is meant to represent the discharging doctor in the hospital sending a final reconciled medication list to the primary care physician of the patient back out in the community. And you can see they scroll sometimes on that line over there. So it's a lot of leakage in the system historically. And finally, and as I think is probably what a lot of folks on the front line just know as common sense, but the research base that is sort of firmed up around this, there's just the complexities of human behavior. So certainly sensitivity to cost, no great surprise, the more things cost, the less people tend to do them. A whole bunch of literature now on how to adjust insurance benefits to prompt medication use and adherence. Certainly all the experience in literature around not just health literacy, which we hear a lot about, but basic literacy, period, cultural issues, cultural diversity, cultural barriers to not only getting care, but getting the most out of care. And then increasingly, and I'm sure this is a term that's come up a lot, and it's one of the health policy buzzwords of the year, clearly, is patient engagement. And so there's a whole lot of really sort of fascinating experience and research that's firming up around how patients get activated, quote unquote, how they get engaged to take care of themselves and monitor themselves and navigate the system and so on. So it just gets more complex the way we look at it. And finally, last but research, it's about how to get things to happen at one point in time. Well, the whole point of menus for a lot of these patients that we're really focused on here with chronic illness, you got to get them to do it over a prolonged period of time. And a lot of these therapies are really lifelong therapies. So how do you get over this kind of precipitous drop that you see in adherence, for example, in major categories of medical care, including diabetes, which is sort of the top line here, where things tend to drop off after 60 days or 90 days or whatever. This is just a slice out of a report that CVS does every year where they report on adherence statistics by state out of their book of business. And I just find it interesting. They have this category they call first fill persistency, which is essentially patients that picked up the med the first time but didn't do it the second or the third time. So you can see they're in diabetes, where you would think, us lay people would think, well, people ought to be really motivated, right? If they got a diagnosis of diabetes. Of course, they may have diabetes and not know it, but the first fill persistency here, I picked on Missouri just because they're in the middle of the country, in the middle of the alphabet. First fill persistency for diabetes, according to the CVS book of business, is about 66%, 2 out of 3. So it's leaving a lot of people who aren't out there doing therapy. So just to add to the complexity of this, different adherence types matter. This is just referring back to that study from Dr. Stewart that I told you about. So this is one team's version of how to view the different patterns of adherence, and as they've shown that it can matter in terms of cost. So here's the good news, just to race onwards here. The glass half full interpretation of all this is there's a lot of stuff going on in the healthcare system now, which is converging or could converge faster to enable better medication use. And probably top of the list is the healthcare IT deployment that's going on with electronic medical records and electronic prescribing and patient data exchange and all that. But it goes on through a number of other categories. This is just our version of how you could tally it up. So care coordination, such as you see in the patient-centered medical home, the payment innovations that are supporting care coordination, quality improvement programs, the patient engagement techniques out here, product innovations that can range to mobile apps on adherence, new ways of packaging medications, and even new ways to formulate medications, to dose them differently and all that, and then the research that supports that. I threw up a little graphic here. We did an exercise 2 years ago, which we're sort of continuing, which we call our roadmap exercise on this, to try to show how all this stuff should come together and then inform discussion about how we could make it happen faster, because that, in a lot of ways, is the challenge. How do we make this stuff come together faster? And in particular, faster to achieve 3 things, a triple goal here again. So first, patient goals. There's a lot of ways, we won't do a whole morning just on patient goals, but basically how to get better outcomes that also meet patients' expectations for quality. The cost of doing this. And then finally, I think increasingly important, what you might call total medical expenditure. And so a lot of, as again you may know, a lot of the thrust of what's going on in payment reform out here these days is around how to achieve a lower or a tamped down level of total medical spending from patients over the course of the year, or 2 years, or whatever the case may be. So again, this ties back to what the Congressional Budget Office found. Maybe we could afford to spend more on medications over the course of the year because we're going to get lower medical spending at the end of the year. So I'll just very quickly tell you sort of where we're going on this in an attempt to make some contribution to, as I say, sort of speeding this up. And it's about really engaging all the parties to this in a look at how to put this all into one framework. And it's a framework around how you literally maybe, if you went up to the whiteboard and you wrote down on the left-hand side everything you can do to coordinate medications well for a patient, and then array that out over time. Who would do what when with the patient, for the patient, and including the patient, him or which is that there's certain things that you can do that prompt better medication use and better adherence in particular. So various forms of medication review, I mean, stopping at some point in the process and saying, what is this patient really on? We have a record that really shows what they think they're on. There may be stuff back home that we're unaware of. So doing that, reconciling meds, synchronizing meds, for example. So when you go to pick up, maybe you're picking up all your meds at one time or on a schedule, that kind of thing, which are not standards of practice right now, as you're probably aware. And I think, again, importantly, how this plays out into different strategies for different kinds of patients, because at least from a payer point of view, this is going to matter. I mean, because from the payer point of view, it is going to come down to, well, how much am I going to spend on what kinds of patients in order to reach what kind of goal? So the pattern of what happens is probably going to be different for patients who have got simple hypertension and maybe just on hypertension meds, versus those who are diabetic and hypertensive, versus those who are hypertensive, diabetic, and have depression, and at any given time, upwards of 20, just the general population, that may be up to like 20%. Not to mention going on in serious mental illness, as we saw. So it's important now to try to define what those key tasks are and how they array over time. And I think, again, from a pharmacy perspective, and this has been a raging debate and interest in the pharmacy world for a long time, where does pharmacy fit in? Because this really does compel a team approach. It may not be a team that's right in the four walls of the doctor's office. In fact, it probably won't be for most patients in the country, because most patients in the country now and for the foreseeable future are probably literally going to get a prescription at a doctor's office or at some clinic at one physical place, and they're going to go fill it somewhere else, and then they're going to go home. And there's going to be, in effect, a virtual care team, or should be, in order to meet these goals, meet these demands. So the question of who's on that team and where and how they're integrating and how they're collaborating becomes very, very important, and it tees up a lot of questions, for example, as to what tasks might be conducted in the retail store by the pharmacist, or perhaps by the nurse practitioner at the front of the store, in the retail clinic, the mini clinic, or the take care clinic, or whatever the case may be. So again, figuring out in this system how we're going to do this virtually becomes very, very important. Not to be redundant, the team, it's not just providers and the patient, it's non-professionals like family members, and it could be, and in some instances, non-humans. So where you insert things like compliance packaging, packaging the meds in one of those sleeve packs that may be on a calendarized basis. And what we may be seeing, and we're seeing some instances of this now, glimpse of the future, is pharmacy organizations taking on an even more direct role in this. So, as people may or may not be aware, Walgreens, just by example, is a fully at-risk partner right now in 3 accountable care organizations around the country, meaning that they're teamed up with delivery organizations, hospital and physician practice systems, to try to deliver seamless care, coordinated care, which will hit targets of total medical spending going forward. So this may be something that's in your future. So I'll just end on some key issues. Hopefully this is useful. I mean, a lot of this, it does come down to IT in a lot of ways, getting complete, accurate, real-time med data to providers right when they need it. Hard to see how you can make substantial progress without doing this. We're still not there. We do need to drive more consensus in the system around who's doing what to whom and when, and which will determine in a lot of ways what gets paid for. More experimentation with this sort of virtual team concept, and just basic concepts of accountability, because one could argue that med use is in a lot of ways one of the areas where we have the least accountability. Patient can literally walk out with a prescription and nobody's paying attention, including the patient, until the next time the patient shows up. So again, good med use should be the signature of patient-centered care. Maybe that doesn't rise to the level of innovation, but it sure would be disruptive and an improvement going
So thank you very much.